it's making me question a little bit. We're getting much better at attaching what we can do in screening to certain diagnoses that I think were at one point felt to be the problem. Like if you could identify everyone with hypertrophic cardiomyopathy 20 years ago, that was a challenge, but if you could, you felt like you won because that was the issue. But as you pointed out, if 50% are unexplained deaths, and that is maybe less, I mean, identifying that's important, but a larger chunk of folks are maybe not falling into that category. That's not really what's killing them. And the ones that have hypertrophic cardiomyopathy, it's unclear within that group how many don't end up having the problem. So it seems like it's the other half that's becoming increasingly relevant. How does the risk stratification work in that group that has it? And what about all these folks that, again, maybe 50% of sudden unexplained death? What about that group? And do we have some understanding of what's our speculation of what's really going on with those folks, and how is our screening capturing or not capturing that? Does that make any sense?
It makes a lot of sense, and we could spend the entire morning talking about the topics you brought up. I mean, I think there are two very important things you raised. The first is the issue of conditions that screening, even the best possible screening, can't and won't detect. And I think it's important for all of us to remember when we talk about screening, no matter how much we believe that screening is good, that we have to approach this with some equipoise and realize that it's imperfect. And as the story of the sudden unexplained death, part of the cardiac etiology evolves, I think we'll understand more and more how screening is impacted by that problem. The second thing you bring up is variable risk associated with specific diagnoses. And this is actually a relatively new concept even within the cardiology world, and I think you're going to hear more about this from Mike with respect to long QT, and we can talk about this with HCM, but it's quite clear that risk is not created equal among a population of people that have a specific disease. So when we think about working with our patients to determine the best strategy after a diagnosis is made, this is much more complicated than it used to be. And we still don't have all the answers, but I think we're moving much more away from a paternalistic binary, yes, no, you can't play sports, to more of a shared decision-making model in which risk and what we know about risk, and importantly what we don't know about risk, is discussed with patients and the other stakeholders.
Great talks. Wanted to talk a little bit more about the sudden unexplained death and trying to understand the etiology in those cases. So, are they electrical disease that we don't know about? I think Dr. Sharma brought up the idea of the T-wave inversion and the inferior lateral leads, and maybe the manifestation of certain diseases haven't come out quite yet. So is it HCM that hasn't quite blossomed? Could you guys maybe touch on that for a little bit?
Yes, I mean, there is certainly a paradigm shift that structural diseases may not necessarily be the commonest causes of death in young athletes, and there are several studies that have shown this, and our study showed a 40% prevalence of sudden death with normal hearts. Clearly there may have been a tertiary bias because we were a tertiary centre, but then a subsequent study from New Zealand and Australia, a prospective study, showed that in 40% of cases of sudden death in the young population, the PM is completely normal, and Kimberly's work on the NCAA has shown exactly the same thing. In our experience, certainly when we examine first-degree relatives of victims of sudden cardiac death with normal hearts, we find a diagnostic yield of around 52% of individuals with inherited ion channel diseases. So we've got the answer in about 52% of cases, but there are 48% of cases that we don't necessarily get an answer to, and these may be incomplete expressions of ion channel diseases, incomplete expressions of cardiomyopathies, or even diseases that we haven't learned to recognize as yet. Clearly, one cannot exclude the possibility of congenital electrical accessory pathways. They're very difficult to diagnose at autopsy, or even drug-related deaths, which we tend to shy away from sometimes.
I'd also comment that, Dr. Mike Ackerman is here, and his group has done a lot of work on the molecular autopsy and genetic testing post-mortem, especially in these cases of sudden unexplained death. And depending on the age group and age range, sometimes up to 46% of those individuals do have a genetic abnormality that would suggest that they died from an ion channel disorder. Again, we don't know if that's a detectable condition by ECG. We don't know what the phenotype would look like or the expression of disease, but I think it's a very important group to understand that within that structurally normal group are probably some things that we don't know about yet, and then a large group of individuals that we do know about yet, but that went undetected, either ion channel disorders or ventricular pre-excitation, Wolff-Parkinson-White.
Yeah. And I would just add that the autopsies that are done in the United States, so when we base our etiology in the United States, they are pretty uniformly horrible. And so really getting much information from them is difficult. And so but it's interesting that studies that are done at a tertiary center where the autopsies are quite good, like at Sanjay's center, really are showing the same thing. But when you start looking and doing a deep dive into the autopsies, sometimes you're like, how can you even decide what this might be?
I had a couple questions. First for Dr. Harmon. You did a great job of showing me who was at high risk, particularly in college athletes and in NCAA. What about that break point of 35 and higher? And for Dr. Dresner, can you apply the same ECG findings for those older individuals as far as risk and using that criteria?
So if you're looking at the individuals that are 35 and older, it's almost all coronary artery disease. And so you go ahead and answer John's question. You can't really apply the same screening strategies. And so that's a whole nother group of athletes that we need to figure out how and when to screen. And Mike Emery's doing a lot of that at his center. And Aaron, that's something that you're doing a lot of, working with older endurance athletes. But they're different, and they need to be thought of as a separate category than our high school and college athletes.
I would add to that, the international criteria have an age range of application that's 12 to 35, and a group that we say when you're over 30, and really recognition that some of those individuals who are over 30 may have occult or silent coronary artery disease, may have had some sort of silent ischemia, damage, infarct, et cetera, that we don't know about, and may manifest changes on a resting electrocardiogram that should alert us to not just rule out some of these genetic heart conditions that we've heard about this morning, but to rule out sort of standard cardiovascular, atherosclerotic coronary artery disease in those individuals. And we'll talk about that, so it's really important to recognize. I think it's also important to understand from Aaron's work with older individuals who died at a marathon, that there's still a group of those older athletes who had undiagnosed genetic heart conditions like hypertrophic cardiomyopathy that in all likelihood, probably over 90%, would demonstrate ECG abnormalities on a resting screen. And so there have been a couple studies that have looked at screening older individuals for occult heart disease, and I think it really falls into different categories. I think if you do a resting ECG, you're going to look for the same disorders that we're sort of looking for in the young, and some of them may still have them that are undetected and may place them at risk. And then there's a giant area that we need to understand more, and Mike Emery is going to speak on this later, on how should we think about cardiovascular risk assessment in that older athlete.
Yeah, Dave Glover, I've got a question. The Italians would seem to have a longitudinally long time of EKG available. I was wondering if their sudden cardiac death autopsies reveal a similar amount of unexplained sudden cardiac deaths, since they would have already done EKGs on all of these athletes or not, or whether you have any information about whether you might find something based on their long-term studies of probably, 20, 30 years now?
Yeah. It's a very good question. Anyone know?
Well, if you look at the previous studies in the New England Journal of Medicine and JAMA, the two studies by Corrado, their main diagnoses were the cardiomyopathies. They were very good at diagnosing hypertrophic cardiomyopathy, and as time came by, they got better at diagnosing arrhythmogenic cardiomyopathy. And certainly, I haven't seen any publications, but listening to them now at meetings, they seem to be more concerned about rather arrhythmogenic right ventricular cardiomyopathy, but just the term arrhythmogenic cardiomyopathy, where they're finding quite a few individuals that were screened with ECG that go on to die and have scar tissue in the left ventricle. I am not so sure about their bias, but they seem to be rather biased that most deaths are structural rather than electric, and I don't quite know how good their molecular autopsy program is. I should also remind you that most of the data that you get from Italy is only coming from one specific region in Veneto, but the new thing now is that we're not very good at picking up arrhythmogenic cardiomyopathy affecting the left ventricle with the ECG alone.
Mike?
Good morning. Mike Ackerman, Mayo Clinic. I just want to thank the four of you for really a great morning session. I thought this was really rich. And a comment I wanted to make about the gentleman who asked what's causing these deaths of these young people if they're autopsy normal half the time, which it could be as high as 50%. And I think Aaron and I are seeing this with much greater frequency in the lessons that we can learn from all of the out-of-hospital cardiac arrest survivors who we do the full drill on them, and up to half the time we're also not finding a reason. And one of the lesions that's emerging in that half, which we would never detect if you died, is PVC triggered VF, where we're now ablating them and potentially curing them. And so that's going to be a lesion that certainly is a contributor to to a significant number of those structurally normal sudden death victims. And I think the reason it's important to keep in mind that is we have to resist the reverse tendency that's happening, which is anytime somebody dies suddenly, it must be heritable, and therefore we must invoke a diagnosis on the living, and then many living family members get labeled with said diseases that we're going to be talking about throughout today and tomorrow morning prematurely. And we need to recognize that a lot of these sudden deaths are going to in fact be not genetic, not familial, and not conferring risk to the family members who are alive. So I think we have to keep an eye out for this, the contribution of PVC triggered VF that we're seeing with much greater frequency, or recognizing now with much greater frequency when we do the out-of-hospital cardiac arrest survivor evaluations.
But would you agree, Michael, that when someone does die suddenly and there's a structurally normal heart, the one thing that people should be concerned about is the possibility of a familial arrhythmic syndrome of some form?
Absolutely. So I think that's, yeah, I think, of course, the genetic heart rhythm diseases, AKA the channelopathies, have to be looked at, but just because the heart is structurally normal when they die, one of the things we're seeing in North America, or at least in the United States, is medical examiners, when the heart is structurally normal, are increasingly signing out the death as familial arrhythmia syndrome, long QT syndrome, almost as if the absence of evidence means they figured it out that it's long QT syndrome. And then with that as the setup to the living cardiologist evaluating the living relatives, they're already one step towards labeling the brother or the sister with a channelopathy as if they've all of a sudden closed the case. So I agree with you, we need to pursue it, but it shouldn't mean that it is already established that that was the reason why they died.
Yeah, I would just add to that. I think we should probably borrow a very sobering lesson from our oncology colleagues when we think about the etiology of cancer. The vast majority of it is not genetic, but simply mathematic probability. Cells dividing over and 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 over. At some point, something may go wrong. The heart's possibly not that different, in that if it's beating over and over and over and over and over and over for a lifetime, there's a small possibility that even in a perfectly normal heart without a lesion or an inherited syndrome, that a malignant arrhythmia can just occur because of chance. And so while I think we all have to do due diligence and pursue familial conditions, we also have to be comfortable with the fact that sometimes there will be no answer, and it's okay stopping there.
Awesome.
Thank you guys again. As I was listening to your talks and also wanting to get your reflections as thought leaders and research leaders in this, one of the challenges I'm trying to understand is trying to develop a set of universal screening criteria to try to identify pathology across athletes, but also acknowledging the fact that there are specific risk groups within that you might be able to target better with different criteria or modified criteria, and resolving all of that against the need for us to develop a set of criteria that most or all of us in this room and beyond are able to use to kind of be a catch net. So I guess the challenge between being precise and trying to identify at-risk groups in a meaningful way versus catching everybody, and how do you resolve that discussion and dilemma?
It's a good question, Ashwin, and I don't know if we have the answer right now. I do think that, when we look at the guidelines and these ECG criteria sets, we have to acknowledge that they try to balance sort of a pragmatic approach. If we make the algorithm too complicated, it's very hard to apply them across, for different users and across populations. And we want to include as much detail as we can, but at the same time, maybe not make it too complicated. When I think about the question that you've asked, will there be specific ECG criteria that is different than established guidelines when we start to think about early detection in specific groups? The way research has evolved over the last 10 and 20 years, I would predict that, I think that over time, we will be able to look at more and more ECGs in black male basketball players, and maybe there is something there. We'll be able to go back and look at those who have died who had a pre-existing ECG and understand that there's another finding we need to be concerned about. It may be that endurance females, we accept T-wave inversion through V3. I think there's undoubtedly going to be revisions and perhaps different criteria to some extent based on sport or sex or race, but it has to be driven by science. It has to be driven by new research, so perhaps with time. Last question for the morning.
Okay, I don't know if you can hear me. It's kind of high. Okay, here we are. My question is more practical. If you take one young athlete and take that person to college and beyond, how often should you be thinking about screening? As you pointed out, the incidence of sudden cardiac death is very different as you look through across the age group and the type of sports they pursued. So I just want to hear the panel's opinion on that.
I'll talk about this a little bit more in my next talk. But the question really is the incidence high enough that you're concerned that you need to find it? Because if you need to find it, then you need to do something like an ECG, because a history physical is probably not going to get it. And if you're okay taking a 1 in 100,000 or 1 in 10,000 risk, some people skydive, some people drive motorcycles. Everybody's risk threshold is different, and so different colleges and parents and individuals are going to have to decide where theirs is.
Are there clinical guidelines a clinician can follow? Because as you know, the patient looks to the physicians for guidance in that regard.
Sure. I can tell you what I do in practice. I don't know if from an ECG standpoint there are clear guidelines on how frequently we should be screening our young athletes. If we look back at the American Heart Association recommendations for cardiovascular screening, which largely use history and physical examination as the screening tool, the recommendations are every 2 years, beginning at age 12 through 18, sort of that first screen in college, and then you're done. We screen athletes who are 12 and older, but we sort of emphasize the high school groups, so sort of 14 and up. In our practice, we use ECG, and our recommendation when we see that athlete who is 14 or 15 or 16 is that as they grow and mature, things can change in the heart, and some of the diseases that we're concerned about really may not manifest until late adolescence or early adulthood. So perhaps one screen is not enough, and we recommend a repeat screen in 2 years. In our university population, we screen all of our athletes who are incoming to the university with an ECG. For me personally, I take care of our men's basketball team, and because I know they're at higher risk and I'm not exactly sure why that is, and I'm overly sort of obsessive about it, I screen my men's basketball team every year, but I'm not sure that really is a standard of care that everyone needs to do.
Thank you.
So thank you very much for the morning. I think we have a refreshment break, and we'll see you back after that. Thank you.